Our focus is on Los Angeles County, which faces perhaps the biggest overdose crisis in its history, with more than 2,000 people dying from drug overdoses every year. Overall, deaths from drug overdoses have been declining dramatically nationwide, including in LA, thanks to increased investment in prevention, harm reduction, treatment, and recovery. But progress has not been equal. Drug overdose deaths are disproportionately highest in Black, Latino, indigenous, and low-income communities. Today, our speakers will present the data, discuss strategies that have led to historic declines, and outline new interventions the county is pursuing to address the disparities. Our speakers today include Dr. Brian Hurley, Medical Director, Substance Abuse Prevention and Control for the Los Angeles County Department of Public Health. Shoshanna Scholar, Director, Harm Reduction Division for the Los Angeles Department of Health Services. Kevin Driscoll, Director of Homeless Outreach Program Integrated Care System, a South Los Angeles nonprofit providing behavioral health, housing, and reentry services to LA County residents. Aurora Morales, Associate Director of Community Initiatives for Homeless Healthcare, Los Angeles, who, among other duties, oversees overdose response teams serving both Skid Row and MacArthur Park. Thank you so much, everyone, for joining us today. We will provide extended bios for our speakers, along with a video recording and transcript by this afternoon. We ask our reporters to post questions in the chat, which we will address after all of our speakers have presented. We urge speakers to monitor the questions and respond in the chat if you're able to. Speakers, please speak slowly for our Spanish interpreters. At the conclusion of our Q&A, we will share very short videos prepared by Rewriting LA County's Story Campaign and by LA for LA. We begin then with Dr. Hurley, who will give an overview of the data, discuss factors that contribute to disparities in overdose deaths, and highlight what is being done to close the gap. Go ahead, Dr. Hurley.
Thank you very much, and good morning, everyone. I'm Brian. I'm an addiction psychiatrist, and I work for one of LA County's 3 health departments, but in the Department of Public Health. And when we talk about overdose rates going down, I'm going to share my screen here real quick. This is what I'm talking about, right? We saw a 22% decline in overdose-related death in 2024 compared to 2023. The biggest drop was in the drop of deaths involving fentanyl, but there was also a drop in deaths involving methamphetamine. And fentanyl and methamphetamine are the top 2 drugs causing overdose here in Los Angeles County. So we have a lot to celebrate, that we're seeing a decline in death related to overdose. But this decline in death related to overdose is not experienced by every community here in Los Angeles County equally. If we look at the racial demographics of overdoses, and this is the fentanyl-related overdoses, we see that Black Los Angeles County residents continue to have the highest rate of overdose compared to white Los Angeles County residents, compared to Latino Los Angeles County residents, compared to Asian Los Angeles County residents. So it remains true that we have racial disparities between who ends up in our medical examiner's office with a overdose death. And because in Los Angeles County, we're a county that has a large number of Latino residents are the highest by raw number of residents who experience overdose, right? So we see disparities related to race and ethnicity here in Los Angeles County. Even though we're in the right direction, these disparities persist. So what is LA County's strategy? Well, I'll start, and then I'm excited to turn it over to Shoshanna to sort of elaborate on. The strategy to address overdose actually starts with youth development and health promotion? How do we work with young people and their families to help support people's emotional development, where using substances is not the best tool accessible to them? And there's a number, in LA County, you have a public health department, mental health department, and health services department. There's a lot, our county is deeply invested in positive youth development and health promotion. We also, as a health department, invest in substance use prevention. But the bulk of our resources actually are in harm reduction and treatment and recovery. And harm reduction and treatment and recovery are categories of services that work with people who are directly impacted by substance use. Now, harm reduction services include things like naloxone distribution. It includes things like test strip distribution. It includes things like working with people who use substances without the expectation that they're ready to entirely stop using, without the expectation that people who use drugs are ready to stop at the moment you talk to them. And we also deeply invest in substance use treatment and recovery services, services that are focused around change-oriented treatments to help people change their relationships with substance use. And there's a popular misconception that the more harm reduction services you do somehow take away from treatment, or the more treatment you do somehow takes away from harm reduction. And that is just not true, right? Providing harm reduction services saves lives, reduces overdose rates, reduces the spread of infectious disease, and increases the chance that people go to treatment. And making treatment more accessible, working with people who may not be committed to abstinence, is deeply important on the treatment side. So both of these arms, we need to do more of both if we're really going to engage our community and try to eliminate health disparities and reach all of the people impacted by substance use that we need to reach in order to make an impact. And the last, part of our strategy is, and measure the effect. Make nice graphs, like the graph that I showed you earlier, right? Like surveillance and epidemiology is part of it. So that's the framework we're in: prevention, harm reduction, treatment, and recovery services. And I think with that, I'm actually going to turn it over to Shoshanna. Shoshanna, I'll go ahead and take the screen off and turn it over to you.
Good morning, everyone. Thank you so much for coming to talk about overdose prevention. This is something that is deeply, deeply important to my life. I spent the last 25 years working in the community as a community-based provider, and now at the county supporting overdose prevention efforts expanding across our work. So LA County is tackling this overdose crisis by investing in healthier neighborhoods and communities. From Antelope Valley to East LA, we have partners, or critical partners, with community-based organizations that provide care and collaborate with other partners to reduce overdoses and save lives. Overdose prevention services are delivered by healthcare workers, community leaders, firefighters, emergency responders, people who use drugs, their friends, their families, and the people who love them. And these are all people who are responding to an understanding that everyone deserves a chance at a healthy, stable, and fulfilling life. So one of the strategies that LA County is using is expanding indoor spaces, or health hubs. They're places where people who use drugs can go and connect with healthcare providers, a meal, a place where they can get a referral to drug treatment. In some places we have clinics, and others we have like rest areas. There are job development pieces that are part of it, and some of them really vary across the whole region. Some of them are smaller, some of them are larger. There's a larger one we'll talk about in a second. There are street outreach efforts through homeless services, but also direct overdose prevention services, overdose prevention teams, meaning like people that go out and distribute naloxone or the overdose prevention medication. And also the teams that Aurora Morales is going to talk about, the overdose response teams, which are unique in the world, frankly, and are a really good example of a creative, important investment that has turned the tide here in LA. Naloxone, as I said, is this overdose reversal medication. It's called Narcan sometimes, and it is available over the counter. And it used to just be used by medical providers, but now community members can use it. It looks like an Afrin spray bottle. If you identify somebody who is not breathing, you suspect an overdose, You can give it to them and save their lives. And this is happening over and over and over again. We've distributed now millions of doses of naloxone across the county, some of it going to the communities that are most impacted, like people leaving jail. The reentry population ends up dying at higher rates than others. So we put vending machines in the jail and overdose prevention training videos so people can learn how to recognize and prevent an overdose, and then how to respond with both rescue breathing and naloxone. And this has resulted in 50,000 reversals. That means between 2019 and now, we have counted report backs of moments where a community member got naloxone and used it to save another person's life. That is really a story about like all of LA becoming first responders and taking care of people who are in crisis and really extending themselves, going beyond to save lives, save their friends and families' lives, support their community, build stronger and safer tomorrows, make sure people are around to do that. We work with, it's important to not do this work alone. So this is not just LA County initiatives. Almost everything that we do is in partnership with other sort of government departments in our world. So working with the sheriff's department, so we can work in the jails, working with probation so that we can make sure that they're extending this message on overdose prevention, but also like a whole range of things, our public defender's office, other parts of our health department, Department of Mental Health, things like that. Like it's just not, you can't resolve the overdose crisis without key collaborative partnerships at sort of the government level, but everything happens at the local level through providers, through the community-based organizations like HOPEX, and Kelvin Driscoll, the executive director for HOPEX, will be speaking soon, and Homeless Healthcare. Aurora Morales is going to be speaking on behalf of that department. There is a network of organizations who know how to do this work really well, and they've trained and taught, they've expanded these efforts beyond the small group that was doing the overdose prevention to a much bigger community-based partnership. So just some examples of the services that might be of interest to this group that are sort of in play right now. We're working with a Native American group that is focused on doing overdose prevention within their community, and they do it slightly differently than others. They work with events like powwows and things like that, and they've been working with their own community to design like materials and other things that are relevant messaging that really connects and is useful. So that is a relatively new but a really cool thing that's happening. We also have the Skid Row Care Campus, which I mentioned is also like unique in the world. It's 33,000, I think, square feet. There's a building that has a clinic with 2 exam rooms, a respite area with beds that are overseen by nurses, drop-in center. There's community groups, trainings, all that stuff. And other like community supportive arts engagement, things like that, as well as like recovery groups. And we're about to put in the first methadone clinic on Skid Row in that space. And then there's large outdoor area. It really honestly is a public square with like a building that houses showers and bathrooms. There are service booths along the side. There's a little stage because they do different activities where people are doing karaoke or performing. It is a really unique, very low threshold space where people can just walk in, and even if they just walk in and out, take a shower and leave, that's a place that has case managers, drug treatment counselors, psychiatric support, healthcare, food. Like there are all of these things that kind of come together, and it's really like the realization of a model that is like, what does it actually look like when you just invite everybody in and let them access the services that they want and be ready to take them when they want them. We do contingency management, which means like using an incentive program to help people who are using substances stay in their housing sites, meaning like the troubleshooting problems that can cause them to be evicted. Like, it really varies the range of things that face like some of the folks who use substances who are in housing sites, and helping them bridge a gap between like just starting out in their permanent housing and a long-term connection and becoming neighbors and friends. And it's been incredibly successful. There is a research write-up about it. Happy to share that with you all before as well. And then the last thing I'll mention is this Rewriting LA County Story campaign. It's about reducing stigma and raising awareness. We launched it in October. It's bilingual, Spanish, English. It really focuses on people with lived experience, frontline workers, and community partners. The goal is to challenge narratives around drug use and replace them with more stories of like humanity, resilience, care, the things we actually see in the world. And I will let my colleagues at Vital Strategies or talk a little bit more about it and show the videos afterwards. So that is what I have to share. Happy to share more if you want to follow up on any of this, but it's my pleasure to introduce Kevin Driscoll.
Thank you. Thank you, Shoshana. We're going to take a break and take a few questions because they're piling up in the chat. So let's go with the first question. And this is for either Dr. Hurley or yourself. So this is from Nestor Fantini from Hispanic LA. Considering that Latinx residents represent more than 40% of the region's homeless population, how is the county adapting harm reduction programs to better reach this community, particularly given that overdose deaths remain high and many individuals have limited contact with county homelessness services? Anyone, either of you?
I mean, I was thinking first it would be great, Brian, if you wouldn't mind talking about the PH mortality report. I think that might actually be of
Yeah.
relevance here.
So we have seen among people experiencing homelessness a reduction in overdose fatalities. I'll pull up the report here in a moment. It just got released, and so I didn't actually get a chance to put it in the slides for today.
It's brand new, really brand new.
It's brand new, like you're literally brand new. Our adaptation is to build harm reduction programs in the communities that are disproportionately impacted, including Latino residents, where we're hiring from that community. We're building, with the health services building drop-in centers in prioritized communities, involving the communities that are impacted. But and so that's literally the strategy, is to engage the communities disproportionately impacted in services. Shoshanna, I'll turn it over to you, and then I'll pull up the report.
So what this means in terms of targeted support for organizations working with homeless people, we have supplied naloxone overdose prevention, trained most of the staff in LA County from LASA teams and from I guess just like county homeless outreach teams is probably the best way to explain it. And we've also paired them with other community-based organizations with more experience than them at like engaging, talking about substance use, talking about overdose prevention. And so between those partnerships and actually buying and providing naloxone out through all of these areas, we have kept like consistent training, technical assistance, and we always check in and make sure that they have what they need, that their staff know how to have these conversations. We've been focusing really on the organizations that do a good job in Spanish language outreach. So just some organizations have better capacity than others, depending on so many factors, but really trying to make sure the ones that have the strong language are also like they're top of our list to make sure that they have access to the medication, to naloxone, and training materials, which are all in English and Spanish. And the other ways in which we access this population, as well as the health hubs, those like drop-in spaces I was talking about, because that's a real strategy that has and distributes naloxone and training and prevention, is by doing larger homeless service in services, like training larger homeless service providers. And we do a lot of work with housing sites. So making sure that there is naloxone on the wall and like a defibrillator first aid kit on the wall. So people, if they see somebody in their housing site who is not breathing, they can grab it and they know what to do. So we spend a lot of time making sure all of the county housing sites have that naloxone and can use it and distribute it. And that they are able to train the people in their houses on how to recognize and respond to an overdose. I guess those are the primary mechanisms for making sure homeless individuals have access to overdose prevention, as well as the jail.
Okay, wonderful. What are we looking at now?
This is the report. So this is the count of drug overdose deaths and the rate.
Breaking news.
For people experiencing homelessness, just released this week. And then this is also the breakdown by race. And you'll notice that the racial demographics are different among people experiencing homelessness than not. You'll also notice that there's remains a gender difference. This is true among people experiencing homelessness and the general population. And you'll also notice a trend by age group, right? So the 25 and older age groups are at highest risk compared to age 24 and younger age groups, which is what we see in terms of other rates. But you'll notice the rates among 25 and older are more clustered among people experiencing homelessness, reflecting that the drivers for homelessness increase the rate of overdose compared to the general community. So this report is actually the subject of like its own press event, and so I don't want to I could spend the rest of our time just talking about this, and I think it's really important that we get to the other presenters. But I did put the link in the chat if anyone does want to review this. It's a rich data set.
Thank you, Dr. Hurley. We will get to everyone, no worries. One more question from Araceli Martinez, La Opinión. Do you have information on which neighborhoods in Los Angeles and age groups are most affected? Well, you just mentioned the age groups. Are we seeing this problem in schools? And what recommendations? Well, these are 3 questions. And what recommendations do you have for families to prevent this problem?
There is no age group that hasn't seen an increase over the course of the overdose crisis. So just to be clear, there isn't a gender or age group that is spared, right? We've seen increases across the board. Now, there are trends, right? So people between the ages of 25 and 65 are at highest risk compared to older communities and younger communities. Overdose deaths tend to be male predominated versus female. And some of the work that we've done in order to make sure that younger Los Angeles County individuals are protected and have the same access to naloxone and test strips and education and information. So we do a lot of partnerships with schools. We do a lot of partnerships with child welfare, or with the child welfare department. There's a lot of youth programming really on the prevention side of the health department's work to really try to get upstream of when people go to develop a use disorder, to make people understand the fentanyl that is in the drug supply is so much more potent and really works differently than opioids have in the past. There's a law enforcement driven thing like one pill can kill, which we talk about because we want to make sure people understand the risks of the drug supply. And that's part of the information we're putting out to the community. So never use alone, always have naloxone on hand. People make sure how they can get help. We have a youth system of care. We have a prevention network. Those are our strategies focused on people who are younger.
Thank you, Doctor. And thank you, Shoshanna, as well. One more question. Does this drop include statistics on Native American community members? I know there are no federally recognized tribes, but there are some state-recognized tribes. So I just wonder if there's statistics directly associated with these communities and what type of programs were implemented for tribal communities.
Just on the numbers piece, the count of Native American and Alaska Native communities in Los Angeles County is relatively small, which makes doing reliable statistics difficult. California has an OD dashboard. I'll put the link in that does capture that, but you'll notice there's a lot of fluctuation in that rate because the denominator, just the low count of the denominator. That said, Shoshanna, you already sort of mentioned our American Indian focused program or Native American focused program. Do you want to elaborate on that at all?
I mean, I would say it's the first initiative here in LA County that's really focused on this. And it was interesting. Before starting it, we met with a lot of Native American groups to figure out like what would be useful, where we should fit in. And this is sort of how those different service providers and organizers sort of pointed us. They said, partner with an organization that has this community at heart and then build it together and sort of follow their lead, which is the model that we've taken on this one. It is one organization though, and clearly like, even though the numbers are sort of small compared to other LA counties, humongous numbers, our goal is like develop a model with this group and then work with them to disseminate and share it. And hopefully it will be relevant, appropriate, and taken up by other organizations serving this community. I will say California has done more sort of to dig into tribal communities and Native American overdose prevention services. I'll try and find a link to plug in here where a number of like tribal leaders came together. They're brought together. I think the Department of Public Health may have been the entity or health services that brought folks together. And there was a focused effort to develop like outreach materials and other things that would be of service and would serve the community and providers working with them. So if I can, I'll drop that in here if I can find it.
Thank you. That's very helpful. Thank you both. Our next speaker is Kelvin Driscoll, Director, Homeless Outreach Program, Integrated Care System, who will describe the reality of Black communities experiencing homelessness and substance use challenges and the importance of treatment that meets people where they are. Welcome, Kelvin. Where is he? Okay, you are muted. You have to unmute.
There
Okay,
you go.
now.
I got permission to speak. I
All
couldn't
right, I'm sorry.
unmute myself. No, it's okay. Thanks, Pilar. I appreciate that. Just a couple of items for me before I get into my talking points. Want to express appreciation for the media partners that are joining us. I do think that you also play a very important role in LA County's story, in that you have a microphone, people are listening to what you're saying. And as you're getting the information today, I really want to encourage you to stick with us throughout this process. The numbers that Brian has shared represent a lot of work by a lot of dedicated individuals in LA County who have been at this. I would be remiss if I didn't say my own team is at this right now. So while we are giving this media briefing, dedicated individuals from Hopix are out on the streets of South Los Angeles doing this work and saving lives. Y'all can come and hang out with us anytime you like. We do this work every day, day and night, and I do think that it would be a real treat for you to see the work live and in living color, that complements the numbers that Brian and Shoshanna are talking to you about today. A little bit about our organization. The Homeless Outreach Program Integrated Care System turns 38 this year, 38 years of going strong. Um, our secret sauce, the areas that we work in, are primarily housing and homelessness services. We do work in the behavioral health space, so that includes mental health and substance use services. And we also do intensive case management services. We have reentry. We are a coordinated entry system lead. We do a lot of advocacy work. Very proud of the over 500 individuals that call Hopix home, who are dedicated and show up every day to change lives in South Los Angeles. The origin story of the organization, if you come and visit us, you'll see a mural at our headquarters where our founder, Mike Neely, said that the idea for the homeless outreach program came to him in a cardboard box. We were doing peer support outreach before anybody else was doing peer support outreach. And our origin story for the work that we're doing in harm reduction very much mirrors that. Shout out to one of my team members, Oscar Ariano, who's on this call as well too, who frankly got tired of seeing members of his community die on the street and thought that we could do something about it. That work would not be possible without key partners like Brian and like Shoshanna, who recognize the expertise of those 500 some odd dedicated people who have superpowers and who know how to do this work a lot better than we do. They've asked me to talk about the realities. The realities are clear and the numbers show them. Obviously, Black and Brown communities disproportionately experience challenges with substance use. They also experience disproportionate challenges with experiencing homelessness. And I do think that Brian's slide around the connection between experiencing homelessness and drug overdose is pertinent. We operate a drop-in center. It's a very nice drop-in center. Again, the invitation is open for you to come and visit. But the strategy there is simple, right? We don't believe, and thanks Shoshanna and Brian for parting with us. Wherever we can, we try and root out paternalistic programs, right, that undermine participants' own expertise in their lives. Harm reduction is exactly what it is. We partner with people to provide healthy alternatives, and we use our lived experience and our expertise as an organization to provide safe spaces. And our drop-in center is one of those spaces. It's a community hub that is beautifully designed, that people come in to visit every day, and they receive a number of services that you've heard today, including referrals. including safe needle exchange programs. Sometimes it's just air conditioning and water. There's actually a really cool like coffee bar and beverage bar and a space for people to just come in and find respite. I think it's some examples of innovation that we're doing in partnership with the county to ultimately build trust and build relationships that leads to healthy treatment options for people experiencing homelessness in Los Angeles County who are as well battling substance use. In the last year, about 8,000 people have come through that drop-in center. I think that's a testament to the county's partnership. It's a testament to the environment that we've created, and it's a testament to the experts who do this work at Hopix every day. Naloxone is a key strategy for us in how we do the harm reduction work. 48,000 doses of naloxone have been distributed from our team members. And a number that is very sobering for me, 599 reversals have happened. So when we say that our teams are delivering life-saving work, it's not just hyperbole, it's not conjecture. Right now, while we are on this briefing, they are doing this work. And 599 people are still alive today because of the partnership with the county and because of the expertise of our teams. Pilar, I will pause there unless there's anything else that you would like me to deliver.
Okay, what we're going to do is go to the next speaker and then take questions
Sure.
for both of you and for everyone. Thank you, Kelvin.
You got it.
All right, we will now hear from Aurora Morales with Homeless Healthcare Los Angeles, who will share her experience with homelessness and substance use and her transition into helping others. Go ahead, Mrs. Morales.
Thank you. Thank you, everyone who's here. Thank you for giving me the floor. I will start off with saying that everyone's experience with substance use and homelessness is very different, and it comes from different places, right? This is one thing that I learned firsthand when I was going through my experience. I was raised in a pretty sheltered household. Um, didn't have didn't have a great community base though. I was kind of isolated in that sheltering, and when I grew up and life presented itself, choices were made and circumstances, arise from those choices, and I ended up experiencing homelessness and addicted to crystal meth for a few years. Um, in that experience, and again, speaking to the reason why we focus on personal experience whenever we're doing harm reduction work, for me, I needed that community base. I needed someone who could come and provide support and provide love and provide non-stigmatic care for me at that junction in my life. In that process, in my personal experience, I gave my life to the Lord, and that's kind of what triggered me going into different spaces. And a lot of what I experienced was thankfully, right, the people that were put in my path were people that compassionately and non-judgmentally were able to connect with me, right? And when it comes to harm reduction services and the way that we interact with people, that's why it's so important to get people with lived experience, as Calvin said, like they're out there doing the work right now, as you know, and they're boots on the ground, and they're actively engaging with folks in a real personal way, right? Harm reduction, as Dr. Brian Hurley had spoken, is part of the continuum. Harm reduction and substance use treatment need to go hand in hand, because the harm reduction element of it is the engagement point, right? When for me, in my personal, experience, if someone came to me and told me you need to change and just led with that, I wasn't really going to hear it. I wasn't ready to hear it. There had been no building, there had been no relationship, there had been no reason for me to want to desire a change, if that makes sense. And harm reduction programs that I encountered, I was actually a client of homeless healthcare before I started my career there. They treated me with compassion. It was low threshold. It was non-stigmatic. And this is really where it needs to start. And this is kind of how we begin to engage these communities. We have been doing a lot of work. Homeless Healthcare has been doing a lot of work in Skid Row and now in MacArthur Park. Thank you to the county for just pouring into these services and giving us these resources that were so desperately needed, because their collaboration has helped us to grow and to be able to expand these types of services that we provide to the communities that we are in. At the Skid Row Care Campus alone, we see 3,000 people per day. And that's like on an average day that we can see someone, and all of those people are being touched. All of those people are being built up with connections are being made, linkages to services are being made. And it's been an amazing experience to be able to be out there. Along with our healthcare hubs, we also have our overdose response teams. These are the ones that I directly oversee at Homeless Healthcare. We do service Skid Row and MacArthur Park. These teams are built up people with lived experience who are familiar with the community, can relate to the community, and are trained at a higher level of overdose response. So we use oxygen, naloxone, we use pulse oximeters, airways, medical tools that we can administer as lay responders to be able to more effectively and compassionately respond to overdoses that we encounter. A lot of times the community members that we service don't have a phone, right? They don't have resources or people who are constantly looking out for them. And that puts them in a more vulnerable state, because if no one's looking for you, if no one sees you, no one's going to know that you're dying, right? So thankfully, we have these overdose responders that are in rotation out in Skid Row and MacArthur Park. A lot of what we do also is again, leaning into the people with lived experience. We get people from the community that can relate. In MacArthur Park, especially because there is a higher Latino population, we have many bilingual staff members on site. At all of our overdose response teams are able to provide naloxone. They're flooding the streets with naloxone. They're picking up haz waste as they're going. They're able to provide naloxone training as well to community members, so that when we're not out there, or when the community is in these isolated spaces, they have the tools and the knowledge that they need in order to save their friends' lives, their families' lives, strangers' lives. We've gotten reports from people that say, "Hey, thank you for handing out that kit. It's helped me save someone's life at the bus stop the other day." And this goes along to just, we need to continue this trajectory, I think is what I'm trying to say, in investing in these strategies, investing in harm reduction, continuing to collaborate and integrate harm reduction to substance use treatment, and continuing to educate the community, right? I know as a Latina woman, I'm very well aware that some of our families, our relatives, there's a lot of convincing that needs to be done on their end, right? A lot of information sharing that needs to happen, because it's different from culture to culture, right? And I think at home and amongst our communities and friends, we can begin that change, right? Those sharing. The sharing of information that is so vital and so needed for this kind of crisis that we're facing. So yes, with that, I will end my comments, and if anyone has any questions, more than welcome to answer those.
Oops, I'm sorry, I was muted. Thank you, Aurora, for sharing your story and the resources that the community has available. So going back to questions now for the last two speakers in particular. Okay. Is there a breakdown in age for Black overdose deaths that you know, or anyone that has this information? Is it Dr. Hurley, maybe?
I don't think we have within category breakdowns offhand, like they're not pre-published. There may be a way of using the California overdose dashboard to do that stratification, but I don't have it readily available right now.
Okay, no problem. All right. Another question I'm curious about, do Black churches aid with Nexalon distribution, Kelvin or Aurora or anyone?
I'm sorry, it was churches?
Yeah, Black churches.
I don't know. That's probably a Shoshanna or Brian question. Not that I'm aware of.
So,
Okay.
so
I-
yes, there are churches that do distribute naloxone. What I don't want to misrepresent is that every single Black church in LA is doing naloxone distribution, but we absolutely do work with churches, and we have a number of community engagement partners that naloxone distribution is part of what they offer. Shoshanna?
I was basically the same thing. I think 10 years ago, we started a program in partnership with a church in South Los Angeles. I don't think that they're still there, but I think that the naloxone continues to be distributed through the folks who work at the church, but there was a partnership for a long time where they were co-located, like a harm reduction and overdose prevention organization on site. It was Mount Olive Missionary Baptist Church. I'm not sure if that's still going, but it's possible.
Okay. All right. So let's go back to the chat then. Pamela and Chang had a question. Is Narcan training available for community members? And how is the county addressing misinformation or stigma that may prevent people from using this tool?
I'm sorry. I just want to make sure I got it. Stigma for which tool?
For, I imagine, seeking help or
Oh,
using these harm reduction therapies. I'm not sure exactly what she meant, but
yeah, got
there's
it.
always stigma around treatment of this issue, right? In certain communities.
Sorry, can you repeat the question?
It's not, I'm reading it from the chat. Is Narcan training available for community members?
Yeah.
That's a question. And how is the county addressing misinformation or stigma that may prevent people from using this life-saving tool? Okay, she's referring to the harm reduction.
To the harm reduction.
Yeah. So, because some communities still misunderstand this harm reduction therapies. How do you overcome that, or how do you explain the role of this uses to people in the community?
Yes, so I can answer that. So it's two questions. So the first one, yes, naloxone and overdose response training is available to the communities. We do provide it in our health hubs. We also provide it on our overdose response teams. I'm sure maybe Calvin can speak to what happens over at Hopix and how their training systems are, but we do provide those trainings. And as far as the engagement, right, and the addressing the misinformation, this is why campaigns like, and we're going to hear about them, Buy LA, for LA, are so important, because on a mass scale, we're able to give out information and kind of bring more awareness and attention to the situation at hand, to the matter. Because the more people talk about it, the more it becomes normal, the more we can address it, right? It doesn't become like this weird taboo, like hide it in the closet type of thing, right? So that's how we're responding and addressing that.
Okay. So there was someone else asking about the same thing, cultural beliefs, stigma, or fears that make it harder for people to talk about drug use or seek help. That's a similar question. Is any other anything else you want to add?
So two things, right? When we talk about stigma, really what we're talking about is what messages do people carry in their heads and what messages do people feed to them? And that's based in language. So it's really important to pay attention to how we talk about people experiencing homelessness, how we talk about people who use drugs, how we talk about substance use as a health issue. And I'm relatively intentional with those terms because I think that the terms we use matter. One way that you can see a demonstration of how to reduce stigma, how do we talk about these topics in a way that don't get in people's way? Go to the byla.org website. It is an anti-stigma campaign called Rewriting LA County's Story, positing an affirmative vision of health and wellness in our community where we take care of people. So that would be a resource I go to. We have toolkits, other information. This is how we should be talking about overdoses in our community that help increase, bridges to communities we need to connect to, as opposed to labeling and stigmatizing them.
Yeah, can I just double tap on that, Pilar?
Yes,
So
absolutely.
Aurora, she's correct. We're also doing education, 9,000 units of education that have happened within community. And Brian's point is really important. I'm always reminded, right, in these spaces when I hear the language that we use in these spaces versus the language that our team uses when they're actually doing this work. They don't use this language. This is not how they talk about harm reduction work at all. Again, when I'm referencing a paternalistic system, right, that this is what I'm talking about. And so I do think that rewriting LA County's story is an amazing resource that if you're dedicated to getting it right, you should visit there. And I just want to emphasize our team members and the experts who do this work do not talk like how we're talking on this call. They don't engage with these terms like substance use, like harm reduction. They don't talk like this at all. So I think
We can imagine.
if you really are interested in understanding how they are combating stigma, two great resources. And again, I'm going to always encourage you to come out and to see the work as it's happening in real time. And just recognize that we're using a language that is very bureaucratic, right? That is very much about county infrastructure. It's very much about data. But in people's real lives, when they're working through these challenges, the language doesn't sound like this at all.
Kelvin, I'm just curious, how do they talk about it?
Well, it's about how they can be helpful, right? It's about how they are, what is it that you need, right? It's about what can we do to help you be safe, right? It's those kinds of languages. It's not at all
Yeah,
about substance use
of
or
course. Yeah,
treatment, right? Like they aren't using those terms, which
yes, yes.
destigmatizes and I would say even more importantly, humanizes people, which is the center of the work. You center the
Got it.
human, you don't center the challenge.
Yeah. Okay. Well, thank you. That was helpful. I'm going back to the chat now. There's a question from Eugene Levin. People often use social media to communicate about drug usage. Any idea how to prevent using channels of communication for distribution of drugs? Well, that's a different story, right? Do you have anything to say about that?
I do, and it's written in the chat. So I understand the
Thank you.
idea of trying to police online interactions, but I'll tell you, the systems that people use to communicate are so easy to adapt around any rules or censorship algorithms. If I'm a parent, I think the key is how do I engage the children that I parent? So I understand the kinds of conversations they're having online, that I create psychological safety for the kids that I'm, like parenting. And there's a whole guidance around this. It's called the Stanford Guide. It's posted on the public health website. There's also a separate resource called getsmartaboutdrugs.gov that has additional, parenting guidance. I would point to that. But it's sort of like, I understand the temptation of, oh, let's get ahead of how like online discourse works, but the truth is there are all sorts of things online that are very difficult to police. Actually getting upstream of this means emphasizing our relationship with our kids.
I just saw that you posted a bunch of links and the information. Thank you so much, Doctor. All right, let me just scroll down. Okay, here's another question from Sway A. We have seen reports about fentanyl being made to look like colorful candy, rainbow fentanyl. What are the most common forms our children might accidentally come across today, and how can parents identify them? Who wants to answer this?
So
Anyone?
it is not true that all fentanyl is being made to appeal to kids. And oftentimes the fentanyl suppliers that traffic fentanyl use candy packages as a way of getting it undetected, right? So safest thing to do, don't take anything that you don't know the source of. If there is any uncertainty, we have fentanyl test strips, We have xylazine test strips. There's other types that, you could test whatever it is to confirm what it is or isn't. But it's a generally disproven trope that I'll just sort of say Halloween candy is filled with drugs. That is almost never true. And what is true is that if people are taking a candy or something, you should know where it came from. And if there's any uncertainty, don't take it. Safest thing to do is not take it. Or if you're worried about it, we do have testing technology like test strips that you can use in order to be able to see what's inside or see what isn't inside.
So when kids get their hands into one of these drugs, how it's just not necessarily because they look like candy. They're taking something else, and maybe it has fentanyl, or is that how it works?
Yeah, so the anecdotes that I'm aware of is somebody went to go buy a pill of something. They knew it was an illicit drug. Maybe the pill was labeled as like Percocet, which is a prescription opioid. But instead of actually having a prescription opioid in it, it has fentanyl in it, right? So let's be clear. Somebody wasn't going out to buy candy, right? They were going out to buy something they understood was an opioid. But the strength, because fentanyl is so much stronger than prescription opioids, generally in pills, the person took it and died. Right, and those are awful, and those are tragic circumstances. It's a circumstance that can be avoided. One, don't buy things from people you don't know. But if for some reason you do, never use alone. Have naloxone on hand. Have test strips available. You know what I mean? Like we want to make sure the community understands, one, the risks, but two, ways of mitigating those risks by never using alone, having naloxone on hand, and having test strips available so people aren't using something they don't know what it is.
Okay. All right, there's more questions. I want to get to as many of them as I can. For Kelvin, can your organizational, this is from D. Anderson. For Kelvin, can your organizational approach be emulated and supported in other areas? It sounds like great outreach. I know a young Black man who died from a fentanyl overdose 2 years ago back east. His girlfriend had naloxone and she survived, but he didn't and died. Can people just walk in off the street and get a supply?
That is the amazing part of this work. The answer is yes. Anyone can walk in, anyone can get the help. That's the whole intention of the work. Can it be emulated? Yes. Is it being emulated? Yes. Do we want to do more? Yes. Does the county want to do more? Yes, right? And so all of these are things that I think you should be writing about. I think what also comes up for me in that question, which I didn't share in my remarks, was the benefit that the county and residents get when they work with organizations like HOPIX, because there is a deep mistrust of government systems, right? And so when you seek help or when you seek treatment, going to a, bona fide, government system to get that help can be a barrier, right? But when you use partners like HOPIX, and again, the myriad of partners who work with the county in this work, we bring a different level of safety to interactions for people who are experiencing substance use challenges. We bring a different story. Lots of our team members have their own stories and their own journeys, and they use that as a superpower in their work. And we are very intentional about removing as many barriers to safety as we can. And if naloxone is that safety, rest assured that our teams are going to do whatever they can to make sure that people don't run into barriers as they're trying to get a hold of that resource.
Here we go again. Muted. Reporters, look at the chat because Anna Gorman is writing some great ideas there for you. I would say that going out with an outreach team is probably top. It would be my favorite one. Okay, let's see. More questions. I have a question for you, Aurora. What do you think drives, and this gotta be short because we gotta go to the videos, but what do you think drives the overdose deaths? Is there a tipping point that you can recognize, or are mostly or they are mostly accidental? Just 2 minutes, please.
So I would say that when I started working at homeless healthcare back in 2020, we also, along with the overdose crisis, we also saw, COVID hit. People were isolating. People were not able to access services as easily. There was a lot of prior to that, it was mostly intravenous substance use in the Skid Row community only. So I'll speak to where I was and what I can speak to. A lot of the overdose deaths that we saw kind of spiked there. And it was again attributed to the fact that people were using fentanyl, and it was done intravenously. The community did move to smoking more, which is a less lethal method of using a substance. And in the Skid Row community, we were able to begin sharing that, sharing information and giving out naloxone. The county was super helpful in just opening the floodgates for us to be able to have all of that naloxone into those communities. I would say that overdose deaths, for the most part, are not intentional. Like, substance users aren't just trying to go and purposely kill themselves, because I know that I'm not sure if that's kind of the narrative that is being tried, is being tackled in that question. But yeah, it's not like it was done on purpose, right? And a lot of things can be done now, and we've learned a lot since then, right? That can be done now to prevent that and kind of create these safety nets so that people don't end up in these kind of crises anymore. So yeah, hopefully that answers the question.
Thank you. We
Pilar,
appreciate.
can I uplift one
Yes.
more thing that Brian said that I think is really important?
Really quickly, because we have to go to some videos we want to show.
You got
Just
it.
1 minute?
I'll be 30 seconds.
Okay,
There was a
perfect.
question around how you address stigma. You heard Brian mention never use alone. I'm sure you've never heard that before, right? That's really important. And also the naloxone piece around overdoses is really important to highlight the life-saving work that's happening with those treatments around stigma. Just two things I think are really important to reiterate.
All right. Okay. Thank you so much. We appreciate every one of you. To close, we have asked Shoshanna to share several very short videos produced by Rewriting LA County's Story campaign and by LA for LA. We will send links to these videos, which reporters are encouraged to use and post as they see fit.
Do you guys see the screen?
Yes.
Black screen? Okay.
Sin los servicios y la ayuda que estoy recibiendo, yo estuviera muerta. Estuviera muerta. Nos trataron como humanos, pues nos dieron esperanzas de vivir.
Estoy atendiendo mis citas, las de mis hijas, me he vuelto responsable ya.
Sé que esto si me ayudó a mí, puedo ayudarle a otras personas. Estamos salvando vidas en el condado de Los Ángeles. Sin los servicios y la ayuda que estoy recibiendo, yo estuviera muerta. Estuviera muerta. Nos trataron como humanos, pues nos dieron esperanzas de vivir.
Estoy atendiendo mis citas, las de mis hijas, me he vuelto responsable ya.
Sé que esto si me ayudó a mí, puedo ayudarle a otras personas. Estamos salvando vidas en el condado de Los Ángeles.
The stigma that we get, we're just like horrible people.
I want us to get to a place where when we see someone having a tough moment, we recognize that their humanity is as valuable and irreplaceable as our own.
We're trying to keep them safe.
If you want people to have a better behavior, you should give them the resources to achieve that.
My name is Riley, and I'm rewriting LA County Story.